we might make a little start now. I know people are still joining, but I might, we're gonna start with Danielle, and then Jenny will be presenting, and then Mike. Unfortunately, Gemma isn't well today. She's given us a recording, but we're going to give everybody the link to that. So at the end, I'll say a wee bit about what was in her recording, but we'll then give you the link so that you can go and see that. Yeah. So Danielle, if you're happy to get your slides up and say a wee bit about yourself. That's brilliant. Thank you. Thanks a lot.
Can you see that, Sinead? That's all come up? Great,
yes,
perfect. Thank you. Thanks very much, Sinead. Really excited to be here at the HDR UK Wales Connecting Expertise webinar, and thank you for organising this with a focus on preconception health. My name is Danielle Shoemaker. I'm a Senior Research Fellow at the University of Southampton, and my work is focused on all things preconception health and care. And I am part of the Executive Committee for the UK Preconception Partnership. And so I'm going to talk to you today about the work that the partnership are doing with a focus on data. So a little bit about what we've achieved so far, what we're currently working on, and our plans going forward as well. And as Sinead already mentioned, and as the title suggests, there will be plenty of opportunities to get involved and collaborate. So please do get in touch. I think I've seen just from people coming into the webinar today, there's quite a few UK Preconception Partnership members on the webinar. So some of this that I'm going to talk about may be quite familiar to some of you already. But just for some background, the UK Preconception Partnership was established following publication of the 2018 Lancet series on preconception health, with the aim to translate the evidence presented in a Lancet series on the importance of health before and between pregnancies into policy and practice, also to normalise and support preparation for pregnancy, and ultimately to reduce adverse outcomes during and after pregnancy, helping to support healthy and happy families, as you can see in the picture here. The partnership is co-chaired by Professors Judith Stevenson and Keith Godfrey, and it brings together over 200 members at the moment from across the UK who all have an interest in preconception health. And we hold 2 online roundtable meetings every year to share updates and to hear about all of the amazing work that our members are doing. And we also run several subgroups, for example, focusing on mental health, primary care, data, and also supporting early and mid-career researchers. As a partnership, we share a vision of a society where preparing for a healthy pregnancy and parenthood is a routine part of life, where healthcare and wider environments support well-being before pregnancy for all families, and where inequalities in maternal and child health are significantly reduced. And ultimately, we want to improve life chances of the next generation by supporting better physical, cognitive, and mental health from the very start. Collaboration is absolutely central to achieving this vision, and that includes collaboration on data-based research projects. And members of the partnership have worked together on various projects with more to come. So in my presentation today, I will give you a brief overview of some examples of the projects that we are working on and collaborating on. So in 2019, members of the partnership published a proposal for annual reporting of preconception health metrics, with the idea to use routinely collected data to describe population-level preconception health in England, helping to answer questions such as how well are people prepared for pregnancy and how is this changing over time. These metrics would include factors such as health behaviours, like diet, other risk factors like smoking, for example, in the picture here, but also wider determinants of health. The ultimate aim for these annual report cards, as we refer to them, would be to hold governments and relevant agencies to account for delivering effective interventions that improve preconception health, based on population needs that we can identify from the data. To create a first preconception health report card, we collaborated with the Government Office for Health Improvement and Disparities, who are responsible for public health surveillance in England. And while there are several different routine health data sets that can ideally be used and combined to create a really comprehensive picture of what preconception health in the population looks like, we decided to make a start with one of the key data sources, which in England is the National Maternity Services dataset, which includes all pregnant women in England from their booking appointment through to delivery of their baby. And the information collected at booking in early pregnancy includes over 20 different measures that are relevant to health before pregnancy, including things like wider determinants of health, like employment. Women are also asked whether they started taking folic acid before pregnancy. If they smoked, they're asked if they quit before pregnancy or during pregnancy. And they're also asked about a whole range of pre-existing physical and mental health conditions that they might enter pregnancy with. And overall, based on this national data, we found that 9 out of 10 women enter pregnancy with potentially modifiable factors that could impact pregnancy and birth outcomes. So we looked at risk factors like folic acid, obesity, smoking, and pre-existing health conditions. And in addition to an overall picture of what preconception health looks like, the data also show large inequalities in preconception health, including in these risk factors that are strongly linked to increased risks of pregnancy and birth complications. So we found, for example, that women from Black ethnic backgrounds are more likely not to take folic acid before pregnancy, and also to enter pregnancy with obesity. There's also really stark inequalities based on where women live. So those living in the most deprived areas are 3 times more likely to smoke around the time of conception and to enter pregnancy with pre-existing mental health conditions. We know that women from ethnic minority backgrounds and those living in more deprived areas, they also have poorer outcomes during pregnancy. So supporting them to optimize health before pregnancy and to enter pregnancy as healthy as possible is absolutely critical, which is highlighted based on these data. The idea for our initial report card was to inform ongoing monitoring or surveillance to track changes in preconception health over time and to inform policy and practice based on trends in the data. A number of preconception health indicators are now routinely reported on Fingertips, which is England's public health surveillance platform. And the graph at the bottom of my slide here shows why this is so important. We found that folic acid supplement use before pregnancy, for example, has fallen over the past 5 years, including across all ethnic groups and also with really large differences based on where women live in England. And we've brought this to the attention of policymakers, and some of you may have seen the renewed Women's Health Strategy for England that was published last week, and it now includes an explicit action point about reversing this trend in folic acid supplement use before pregnancy. So based on our work in England, colleagues in Northern Ireland and Scotland, some of whom are on the call today as well, have also looked at routinely collected data on preconception health indicators, and hopefully some of the data across multiple nations will support local advocacy for further support around pregnancy preparation. As part of the partnership, we've also gone beyond the UK with all of this work around measurement and monitoring. The ultimate goal would be to measure and monitor how well people around the world are prepared for pregnancy and parenthood. So we can learn about where preconception health is going in the right direction, for example, and what policies and care and support systems in the UK or perhaps in other countries work really well or not to optimize and improve population level preconception health. Many countries don't have the routine health data that we have in the UK, and measuring and reporting over 20 measures may not be a very realistic ask. So as part of this international project, we aim to agree on the core preconception health indicators that we could recommend for global monitoring. And this involves, in the first instance, a Delphi survey to score the importance of a list of preconception health indicators and a consensus meeting later this year to agree on what these recommended core indicators would be. If you'd like to share your thoughts on what the data should be, how we should measure how well people are prepared for pregnancy and parenthood, then please scan the QR code here, and I can pop a link in the chat later as well to complete our Delphi survey and get involved. Coming back to the UK, I'm really delighted that the UK Preconception Partnership and the Mirada Partnership are collaborating on data and preconception health. So with thanks to seed corn funding from Mirada, we are currently working on a project that aims to bring together academics, clinicians, policymakers, and the public to define how the Mirada data can advance research on parental health before and between pregnancies. We will hear more from Mike about Mirada later in this webinar, but in brief, for those who are not aware, it includes harmonizing of data across multiple data sources, including cohort studies and linked routine health data from multiple studies across the UK. A lot of these studies have already used data, for example, to look at health during and after pregnancy among mothers and children. And what we aim to do through this project is to find out what data are available on health before and between pregnancies, ideally not just among women, but also among men or their women's partners, and how we can use that data to address gaps in the evidence. So at the moment, we have an ethics application for this project under review, and we're doing, well, in the next couple of weeks, 2 short surveys to identify and to rank the most important research questions that can be addressed using the data. And we'll then have a workshop on Monday, 15th of June in Southampton, and also online to agree on what these most important research questions would be that we can answer using available data through Mirada and potentially other data sources. Also with a discussion on collaborative funding applications that we could work together on at the end of the workshop. So members on the call who are part of the UK Preconception Partnership will have already heard about this study, but if anyone would like to get involved in this as well, please let me know. And lastly, Jenny and I were really keen to talk about another upcoming opportunity, but unfortunately we don't have final sign-off from the NIHR on this yet. But just to really briefly mention what is going to come very soon. So the NIHR are funding a large UK maternity disparities consortium with the aim to improve maternal health and change the really sad statistics that groups of women, including women from Black ethnic backgrounds and those living in more deprived areas, are much more likely than others to have poorer experiences and outcomes during pregnancy. And we believe that care and support to address this needs to start before pregnancy. And we're really pleased that members of the Preconception Partnership are leading the preconception and inter-pregnancy health theme in the consortium, aiming to implement and evaluate a blueprint for coordinated preconception inter-pregnancy care and support that we hope will be effective at reducing maternity disparities. This will also involve a lot of data-based evaluation that Jenny and others are leading on, and we hope that this will all kick off this summer, and we'll then have more details on how others beyond the consortium can get involved in this as well. All of this that I've talked about can only happen with lots of people involved, so a big thank you to members of the UK Preconception Partnership, those who are part of our executive committee. Thank you to Sinead and the Mirada Partnership team for the collaboration and those involved in the Maternity Disparities Consortium. That's my contact details, so I can already see there's things happening in the chat, but feel free to get in touch if you'd like to become a member of the Preconception Partnership so you stay up to date on everything that we do. We've got a website and a LinkedIn page as well, so I'm very happy to answer any questions. Thank you, Sinead.
Thank you very much. No, thanks a lot. If people have questions, would you stick them in the chat, and we're having a wee discussion at the end of all the presentations. So thanks very much. And we'll ask Jenny now if you'd be happy to share your slides and to say a wee bit about yourself and your work. Thank you.
Thank
Thanks
you
a lot.
for doing that. It's going to move to a slideshow. Is that good? Can you see?
Yes.
Okay, I've got that thing where I can now see slides and not you, or you and not slides. But thank you so much, yes, for inviting me to speak today. I'm Jenny. I'm Professor of Reproductive Health at UCL in the Institute for Women's Health, and I co-direct a policy research unit in reproductive health. As Danielle said, I was originally going to talk about the data work in the Maternity Disparities Consortium, but we're not quite ready to. So I'm going to speak about a project that we have within the policy research unit, which has been looking at data linkage specifically within reproductive health. The project is reproductive health broadly, so not just preconception, but I will pull out some of the preconception elements of that. And just to let you know about the policy research unit in reproductive health, we started in January 2024, where there are policy research units across different topics and populations, but it's the first time there's been one in reproductive health. And the policy research units are established to provide high quality research evidence to policymakers to help them make more evidence informed policy. We cover the whole of reproductive health for everyone, so it is very broad, and we have a number of projects either recently completed or ongoing, including contraception, abortion for people with complex medical or social needs, looking at commissioning of women's health services, and we have this data project which we are 2.5 years into, and which I'm going to give you some of our early findings and next steps. So I say it's not just preconception health, we are thinking about the whole of reproductive health here. And what do I mean by that? So we, as a unit, we interpret it very broadly as any conditions, illnesses or events that are related to the reproductive health system throughout the whole of life. So it can include things around menstrual health, infertility, preconception, pregnancy, abortion, contraception, menopause, urogynecology, pelvic floor, all these things. As a concept, that is how we would define reproductive health. But as a unit, some of our boundaries are set by what other units are doing. So we don't really do anything on cancer because there's another unit that does cancer screening and awareness. We don't do anything on maternity or officially preconception because that falls under the maternity and neonatal policy research unit. And we don't really do sexually transmitted infections and HIV because there's a different unit for that. But for the purposes of this project, where we're thinking about reproductive health data, we took a very broad definition to allow us to think about it more holistically than just the narrow remit of the unit. And if you think about all those different types of reproductive health experiences, you can see that people would access different types of care in different settings. So they might get some from primary care, they might go to sexual and reproductive health services, hospitals for diagnosis and treatment. If they become pregnant, they'll turn up in maternity services. They might access pharmacies, which they could do in person, or they might buy things online. And then there's also obviously the independent sector in terms of abortion, or private sector in terms of fertility. So lots of different places that reproductive health turns up in. And because you access reproductive health in so many different places, the data about those elements of your reproductive health are held in different systems, and many of those aren't connected, and some of them can't currently be connected, and I'll talk a bit more about that as we go through the presentation. But what that means is that there are many questions, many reproductive health issues for which we can't get a picture across the country, or we can't follow people's journeys either across time or across different bits of the health service. So if someone has a particular illness or episode of care, we often can't even follow that person through the different bits of the system if it relates to sexual and reproductive health in particular. That makes it really hard to spot trends and risks and patterns, and particularly to look at inequalities. And then that really limits the ability to provide better care, to plan services more effectively, and to create better policies. And so that is the whole rationale for this project, that is looking at could we bring together reproductive health in a way to try and fill some of those gaps. So we initially, the unit was funded for 3 years, and so we conceptualized this as a 3-year project. The first year was looking at kind of what is already happening, where have people managed to link data about reproductive health, what different data sets exist, and what are those unanswered questions that the policymakers or service planners would like answered and can't currently because of problems with the data. The second year was all about exploring public opinion about linking reproductive health data together, and do people think differently about reproductive health data? Often it's seen as a more sensitive topic. And then the third year, which is where we are now, is thinking about some of the practical barriers and what would need to be changed in order to make some of these linkages possible. So we did a scoping review in year one. This is now published. I've got a QR code at the end that will link you to our website with all the links to the publications and outputs. In this, we found 272 studies linking data to answer reproductive health questions from 155 data sets. And I will say that is more than I was expecting. But what I would also say is those are data sets that have been linked to answer reproductive health questions and are not necessarily reproductive health specific data sets. And we included everything in this, so not just sort of routine or national level data, but cohort studies or regional data or particular study data sets. We looked at what reproductive health topics were covered, and most focused on reproductive cancers or maternal and child health, and I'll show you a bit more about that on the next slide. We found that very few studies included detailed sociodemographic data, and that really meant that we couldn't look at inequalities. Only one of those 272 studies actually set out to answer public acceptability around linked data in reproductive health. And quite shockingly, really, less than 10% had any patient or public involvement in their data linkage studies. So with the domains, we mapped them according to these domains of reproductive health on the side. And as you can see, the dark green sections at the bottom, that's reproductive cancer and maternal and child health. And so that in part reflects sort of existing good data sets. So cancer registries, for example, or where things have already been linked. So the maternal and child health, it was often things like the hospital episode statistics linked with CPRD, so a primary healthcare data set. That link is established and existing, and therefore people can come in and answer more of those kind of questions. You can see preconception there at the top. There were only 3 studies that were within preconception health, one back in 2004 and 2 in the early 2020s. And those 2 in the early 2020s are both from Lambeth, where they have linked their hospital data with mental health data, and then have been looking at questions around people's mental health and their pregnancy outcomes. So speaking to policymakers, clinicians and researchers to see if they felt that there was a need for any improvements in the data, or if linkage of the data would help, they expressed that a desire to be able to understand reproductive health across their life course and people's journeys across health services. They had many unanswered questions, or questions they couldn't answer because of the way the data currently are, such as how many people are on contraception, which contraceptions are they on, how is that changing over time, what's the proportion of unplanned pregnancies, lots of questions around reproductive health. And they also really wanted to be able to better understand inequalities through this data. And so coming out from these consultations, there was strong support for linking data to be able to answer these questions. And then we were identifying data sets from some initial work of kind of what we already knew existed, and from these consultations with experts and with others, and identified data sets. And then we identified more data sets in our scoping review. And then once we sort of put those together and deduplicated, we had 247 data sets containing reproductive health information. As I said, not reproductive health specific data sets, but data sets containing reproductive health information. So potentially lots of data out there that could be used. And we are currently working on a way to visualize that and make that available so that people would be able to see what data sets exist, what reproductive health topics are contained within them, and what population level data is contained within them, so that you could see which data sets you might be able to use to answer different questions. I'm just briefly going to sidestep away from the policy research unit work to talk about the work of Catherine Stewart, who's a PhD student with us in UCL, and she is doing her PhD using linked national data from the eChild database. So this already links maternity services data with hospital episode statistics data and the national pupil database, that's education data. It also has social care data in there. And her PhD is looking at how women's health before pregnancy, so with particular health conditions impacts pregnancy outcomes, longer term child health, and early educational outcomes. And again, eChild is an existing linked data set. It wasn't set up to answer preconception questions, but once these data are linked, as I said with the HES and the CPRD data, people can come in and ask all these other questions about them. So they're a really valuable resource to have those existing, and they take a lot of time to put together. As part of her work, she's done a really thorough piece of work around the maternity services data set, creating a data resource profile. Danielle presented some of the data that she analysed and that's on fingertips. It's a really useful source, probably our most useful source for preconception data. The data set, I think, is only for England, but as Danielle said, it has data on people's preconception health that can be analysed for those preconception health questions. So for anyone who is thinking about using the maternity services data set, I would recommend having a read of this. It's really useful. Obviously, there are limitations to maternity services data set being used for preconception, in the sense that it's only people who get to booking, and so we're missing all the pregnancies that don't get to booking, but it is still helpful. There are lots of challenges with the data, which I'm sure Catherine would be thrilled to talk you through it in detail in terms of the versions have changed and the completeness and the recording and all those kind of things. But anyone working in routine data, I'm sure, is familiar with these sorts of things. So I mentioned in the scoping review, we identified very few studies around public acceptability, and we'd already planned to do public acceptability work anyway, but that kind of really made it even more important. So last year we did a public deliberation, which over 2.5 days, we brought together members of the public to deliberate. So it's a method that you use where there isn't like a clear right or wrong answer, and there's lots of nuance and trade-offs and things to discuss. We co-created with lived experience team members all our materials, and we had a very interactive day. So there wasn't lots of like information giving, but lots of kind of working through different case studies and scenarios and sensitivity scales and things to try and explore whether we could create a linked reproductive health data resource that would be acceptable, that would protect privacy and fairness and maintain trust. We recruited 40 people from across the UK who were representative in terms of education and age and employment status, although we oversampled for people from Black and minority ethnic groups, and also for more women and trans and non-binary people, because there's sort of more reproductive health experiences in those groups. Broadly speaking, what we found was that no reproductive health data types were considered off limits, and we talked about abortion, we talked about HIV, some things that are considered very sensitive, and some things that are currently unlinkable and are reported anonymously. People were willing for that to be changed if certain safeguards are in place. In fact, what people said was, rather than, oh, you could never link abortion, or you could never link contraception, everything was considered important and everything could be sensitive depending on the question that you were asking or the particular population that you were asking the question about. So they felt that everything should be included, but everything should be considered on a case-by-case basis with strong protections in place, which of course there are with all these sort of trusted research environments. As I said, the group was sort of representative of the general population, and now what we're doing, having identified some of those sensitivities that vary by different groups, there's work ongoing to explore with some specific groups. We're looking at people with mental health illnesses, Bengali migrant women, and people from the Black and African Caribbean community, to do some more in-depth work with those groups to inform that work going forward. So as I said, coming out of that, there is a willingness to have the linkage if it's in the public benefit, but there are sensitivities, and so we do need to maintain trust. And I think this public acceptability work is really important around doing that. And there are some practicalities that we have to work through. So as I mentioned, some data is currently reported in anonymously, and that makes it completely unlinkable. So some things will have to change in order for those data to be reported with identifiers or with linkage, with information, so we can make linkages. And also, as I said, because the data sits in so many different places, there are multiple data owners, which means data sharing agreements and all these kind of things have to be put in place, which makes it really complex. But those are the things that we're starting to work through this year. We're having a roundtable next week to kind of surface these issues and try and work out how we take things forward. So just to summarize, there is actually a considerable amount of research out there linking data across the UK to answer reproductive health questions, but there are gaps in domains and populations. There is support for linking reproductive health data sets. It is socially acceptable, it is felt to be needed, but there are some practical barriers remaining. And when I say linking reproductive health data in, we are not necessarily talking about creating a bespoke standalone linked reproductive health data set. We're very much trying to explore how reproductive health data can be brought into existing linkages to make those more complete. So just to give you the QR code to get to the Policy Research Unit website, which has all the publication on. There's some images here of our infographic, our full report, there's a blog, and also like the scoping review and other publications. And just to thank the wider data team working on this, all our lived experience members who worked with us on the public deliberation, our oversight group, and the wider team. So thank you very much. My email is on here if you want to email me or the unit and get in touch. I'm very happy to speak to anyone. Thank you.
Thanks so much. Thank you very, very much for going over. And the links that you've given, we can share also afterwards, so that there will be a recording of this. I think there's been a request for the slides, so if the presenters are happy to share the slides, we could share them, and then the links will all work from the slides. We're going to go on now to Mike, who's going to talk a bit about the Merida dataset. Thank you. And if people have questions for Jenny, would you put them in the chat and we'll answer them after this one? Thank you.
Right, just checking on my slides so everyone can see them.
Yes, they're good.
Brilliant, thank you. Hi everyone, thanks for coming. My name's Mike Seaborn. I'm a data analyst and researcher at Swansea University with a background in paediatric pharmacy, neonatology and maternity services. And today I'm going to be trying to not send you to sleep talking about data and what we've been doing with the Merida partnership in trying to harmonise UK's electronic birth cohorts. Before I go ahead, just to apologise about the colour pink, you'll see lots of it. If you like the colour pink before, you might be sick of it by the end of the slide. So here goes. So first, a little bit about us. We're a partnership consisting of the universities of Edinburgh, Birmingham, Nottingham, King's College London, Swansea, which is me, obviously, the Bradford Institute, but more specifically, we represent real-world electronic birth cohorts from born in Wales, Scotland, South London, Bradford, and we have all births in England from the Clinical Practice Research Data Link from the year 2000 onwards. We'll ignore that one. So for background, we know that maternity and infant outcomes are key public health indicators, and there's a lot of traditional birth cohorts which snapshot specific populations of birth by time and region. They quickly become outdated, lacking relevance to later birth or births from elsewhere. And they usually require recruitment and exhibits recruitment bias. So what we need is a real-world data solution for up-to-date population-level data using existing research-ready anonymized data. These can then be used for things like natural experiment related to policy and public interventions. So the problem is that different cohorts that exist currently have different coding systems, units, structure, terms of access, etc. And this leads to difficulties in us working together. So to demonstrate, I've put 3 imaginary cohorts here, and they have exactly the same information about 3 different babies. So what you can see is that this top code here in all of them actually relates to having an APGAR score of 7 1 minute after birth. We have gestational age, we have birth weight, and we have gender, the same in all of them. But what you'll see is that they're represented slightly differently. So this is in a read code, this is an ICD-10 code, this is a SNOMED code. We have gestation that's in weeks here, it's in days here, it's in completed weeks here, birth weight in kilograms, grams, pounds and ounces is a decimal. And then we've got things like gender, which, okay, F you can assume is female, it's easy enough. but then you've got 0 and 2 in other data sets. You don't really know what they mean, but in this case, we do know that they are female. And this is a good example of how we can see that if we tried to compare these, it wouldn't work. First of all, they're not named the same. Second of all, this is a character or a string. This could be a number or a character or a string. We don't really know this information. So the question is, how do we make them function the same, so that we can work together with these different cohorts? But we're going to come back to that in just a little bit. So our objectives, I'm going to talk about OMOP in the next slide, so I'm not going to explain that here. But our objectives were to create a UK-wide resource representing dynamic birth cohorts by bringing data sources together in both structure and content and standardizing or harmonizing the data. So beyond that, then we'll continue to improve and expand upon the core data sets, and then we'll be developing a centralized access point for federated analysis. This is the beast that we refer to as OMOP, or OMOP CDM, and the blue section in the middle forms the backbone. And I've got some zoomed in bits here. So that consists of the table. So the person is where we identify mum, dad, or baby. They all get a person ID. This is where we'll find the basic details and demographics. We have measurement tables, drug exposure, procedures, observations, device exposures, specimens, condition occurrences, death, and fact relationship tables. And that's where my mind was blown at the beginning, and that's where my headache began. So in terms of a method, the key message is that, first of all, no raw data or identifiable data leaves our trusted research environments, or TREs, that you've heard other presenters mention so far. We needed to first decide what we wanted in the core data between the partners within the Mireda partnership. But we also included other data. So where there was a standard code available where we could transform it easily enough to OMOP, we did that as well. But our focus remained on the core to make sure that that was exact. So there is some variation between what data we hold in one cohort compared to another, because we have extra stuff essentially in some of them that we don't have in others. Some of them are a bit more developed than they have been. So for example, the Scotland data set is a lot newer and is still developing and building on the data that it contains. So we analysts then built and cleaned the core data within our TREs. We extracted the metadata using the White Rabbit software, and we uploaded them using the Carrot Mapper. And in that Carrot Mapper, some of our codes were automatically mapped for us. Some of it we had to manually map, which meant that where I mapped something as one term, someone else mapped it in their cohorts another term. So there was a lot of iteration of having to go back and forth. And eventually what we produced was this huge JSON file that represented all of the data that we had in our TREs. And for example, in Wales, ours was like 120 million lines long of code, and that's still growing. So then we would take that JSON file, import it into our TREs, use a product called Carrot Transform, and we'd use that to transform our original data into an OMOP format. After that, we now have an OMOP formatted cohort that is ready to receive data, but ours will look exactly the same as the others for all of those variables that we all match. So it means that one person can write a script to analyze my code and then apply that same code to Scotland or to South London or one of the other cohorts or all of the cohorts, and get similar comparable results out from each of them. We each retained a key, which retained our original identifiers and how those identifiers now actually appear within the OMOP structure. So that means that even though we have some data which is not yet OMOPed, it means we are able to link back to our original data, our raw data, and then we can link to other data sets to bring in more information until we can actually bring that into the OMOP side of things as well. So coming back to this slide, you can see I've got a nice little table here that summarizes the top part. This is not how it looks in OMOP, but it kind of gives you a general overview. So this first code here is a concept, and this actually means APGAR score of 7 after 1 minute. The number is already there, the value is there, it doesn't need a separate value, so that's it, and that represents exactly the same as this SNOMED code, this ICD-10 code, and this READ code. Then we have the length of gestation at birth, that's what this code means, and it's been standardized to 34 completed weeks in this instance. Birth weight is an observation, and that's its concept code, and that's been standardized to grams. And then we have the gender code here, which just means female. All exactly the same, all directly comparable now. And if that was a bit much for you, I thought I'd just put it into more of a cartoony kind of thing. This kind of represents what we've actually been doing. So here we have an OMOP nursery factory. We have 3 different cohorts represented as nappies, bottles, and dummies. They're all different shapes, different sizes, different colors. And those represent the differences in our children, their sizes, their weights, and everything else. And effectively, these all get smushed together. They get fit into a giant machine or software in our instance. And then you have a diligent white rabbit here that's using this carrot software or his carrot tool to control it and bring things out into a nice uniform selection here. So this little guy here and this machine is effectively representative of what I and my other analyst colleagues have been doing in the background, along with the clever software I've mentioned in previous slides. And then these nice little uniform packages here represent what our data looks like when it comes out. It looks the same, it's comparable. We can see that each one of those packages belongs to a different baby. So our core data, we split into several areas. So the first one was pregnancy. Don't worry about these. The only reason these 2 are in different colors is because they weren't common to all of the data sets. So those that had it were OMOPing it. Those that didn't do so. So that's why they look different. We have birth data, infant data, data for kids right through school age where it's available, demographic details for mother and baby. Then we had, initially we thought, oh, well, we need all these data so that we can process everything, because that's kind of how it looks in our original data. But then quickly realized, well, we can't do that in OMOP. OMOP only has a person ID, whether you're a mum, a baby, a dad, hobgoblin, it doesn't really matter. You would have a person ID. So we can't do that. And we needed to find a way in which we could link those to each other and link to a pregnancy. We can't do a pregnancy ID either, or a birth ID as we've got here. So I'll remove those for now. We'll come back to them later. Then we have things like age. OMOP doesn't really like age. So effectively what we have is a date of birth and an event and the date of the event. So you would just calculate what the age is at the date of that event, depending on what the event actually is. And I just highlighted ethnicity and gender because they seem to appear in lots of different tables here. And actually that would all be covered in the person table. They don't change, so they go in the person table. We don't need to worry about it anymore. And then we just have these set of parameters that we then have in addition as part of our core data. And there were other things as well. I think this is a slightly older slide. So when it came to linking the pregnancies, what we wanted to do is look at using mechanisms that were already there. Effectively, OMOP was originally designed as by the US for medical insurance claims. And I don't think linking mothers to babies was a priority for them, so it doesn't really exist. But there are mechanisms within it that we could utilize. So we thought, so if you look at this, we started with a person ID for both our mother and baby. Then we assigned in the condition occurrence table a pregnancy to mum. So this is the concept for pregnancy here. It gets given another ID. That's the 1, 2, 3, 4, 5, 6. And then it obviously has a start date and an end date. And that can then get fed into another table called the fact relationship table. With our babies, then, they also come into the fact relationship table. And these codes here just relate to where this ID is coming from. So this is saying, look in the person table, find this person. This one is saying, look in the condition table, find this instance of this condition. And then we have this ID concept, the important bit at the bottom that says that basically this child is the infant of this pregnancy. This fact relationship table can also do direct links. So we also can put in the baby here and the mum's ID here, and we can say that this is the baby of this mum. And then we have to do the reverse as well and say that this is the mum of this baby. So those side of things are easier, but we had to find a solution to the pregnancy thing, and that's how we did it here. So other people that have approached this have tried different methods. So I think thanks to Spain and Norway, there's a link here. They've actually created perinatal expansion tables. We've emulated these as well because we thought in future we are going to expand. We'll want to collaborate with other people. We want to make it as easy as possible so we can do their way or they can do our way or vice versa. So we have these tables as well. But the important thing is that they are additional tables. They're not part of the OMOP CDM. they're unlikely to become part of it as well. So that's why we took the original approach that I showed you earlier. So as it stands, we now have a combined total of just under 17.5 million live births up to somewhere last year. They've been born to just under 11.5 million mothers. We have 17.3 million pregnancies. The average mother is about 29 years old at birth, and that's including all births, not just the first birth. 99% of births are signaled on in all of the cohorts that we have, and approximately 93% of them are term births. 67% of them are spontaneous, non-instrumental births. It's all there if you wanted to read it later. So in the interest of preconception, it's a bit of a mixed bag at the moment. As I said, it wasn't part of our core data, but we did map additional data as we were working through it where we could. So I've just put a brief outline here of each of the cohorts. So Scotland's still awaiting approvals to link their data to primary and secondary care. So they don't have very much at the moment, but they are working on it. CPRD is as primary and secondary care data. It's currently linkable, and Arturo, who works on CPRD, hopes to OMOP that at a later date. Bradford has primary and secondary care data, some in OMOP format, but all linkable. And in Wales, anything that existed as a code in either the primary care GP data or in the secondary care data, which included lab tests, blood results, diagnoses, all of that has actually already been recoded into OMOP format. So we have that available already to begin with. You may have noticed I missed out South London, and that's because while I've been recovering from OMOP in Thailand a couple of weeks ago, my colleague Steve-O has put together some figures on the London data. So he says that currently they only have 12.5% of mothers have some degree of preconception data. And as you can see, as the further away you get from that, leading up to pregnancy, that drops off significantly. But there is some good news. So I think Danielle mentioned earlier about the report card. I put the link at the bottom here, but you can also get them from her slide. So they've been working with that data, and Stephen's doing a lot of clever stuff with data mining and other techniques to pull the data from there. And it's in these 5 different areas: wider determinants of health, healthy conditions, health behaviors, and so on. And they seem quite confident they will have all of that data into their side of the OMOP table at some point soon, hopefully. So after that, I just want to thank everyone involved so far, and I have some links here. So we have a paper that is currently with nature.com at the moment that outlines our data, what we've done, where we go in, what we've used, and so on and so forth. So there's a link there on the top. We also have a GitHub where we've started to upload information along those lines, changing protocols, helpful scripts and things like that will all be uploaded in time. So that's an ongoing thing. And then if you just wanted a rough overview of what the collection entails in terms of OMOP data, you could then go to the HDR UK link there and have a look at the details. Otherwise, that's all from me, and thanks for listening. I hope you're still awake.
Thank you. Thanks very much. So we were going to have a talk from Gemma, which was about doing a survey with women and their understanding of preconception health. She's not well, and she's given us a recording. We're going to share the link to that recording with everybody after. The main things were that for many women, preconception health is really just about when they're about to have they're intending to have a baby. It isn't seen as a life course. And it's about diet, it's about being physically active, it's about existing conditions, having them managed. So if you want to go on the link after, you can see a bit more detail on that. So right now, there's quite a few questions in the chat. So I don't know if Errol, you'd be happy to say about, because you were saying, has anyone done the pregnancy alcohol exposure pathways, and if the associated measures, and if they're willing to share them with you. So I don't know if you'd be willing to say a wee bit more about that.
I'm just interested in seeing, and thanks for picking up on that, Sinead. I'm just interested in seeing any of those pathways from other parts of the UK, and specifically interested in the measures they have associated with them. We're improving ours within an Iron Bedouin University Health Board, and we do have some that we can kind of compare with, but I'm particularly interested in that measurement aspect. So I've just popped my email address in the chat bar, and yeah, I'm interested if people either want to talk about that now if we've got time, or maybe just email me separately. Thank you.
I don't know if any of the speakers know anything about the alcohol exposure pathways at all.
Not specifically about exposure pathways, but in the preconception report card, we did not report on alcohol use because it was really poorly underreported in the maternity services data set. And I think there was another question about has that changed? So we looked at 2018, 2019 data initially, and through the eChild data set that Jenny mentioned, several people are now looking at sort of follow-up data that came after that as well from the new version of maternity services data. So I don't know yet if things have improved, but I suspect it is underreported. So I'm not sure we're going to be confident reporting on that. But I do know that there's colleagues at the University of Hull who are doing, I can pop a link in the chat for the NIHR funding project that is coming to a close soon, I think. But they're working with health visiting and collecting data around alcohol exposure in parents, I think. So there I'll pop a link in the chat. But Leslie Smith and Jane Walker will, I'm sure, be very happy to talk to you about that.
Oh, that's really helpful. Thank you.
We ask families about alcohol use in our Born in Wales, so there may be some that's more survey linked to the routine data. So Patricia, go ahead. I think you're on mute at the minute. I can't hear you at the minute. I don't know, maybe put it in the chat if that's okay. Yeah, sorry. So if you put it in the chat and we go down to the chat.
I think there was a question in the chat about whether we could use the data sets from Patricia to look at first pregnancy. I don't know if that's the question you wanted to ask right now.
Yes.
But I can answer that if you'd like. The answer is yes and no. we can subtract sort of mum's date of birth from the first pregnancy, but sometimes we're not necessarily sure that we do have the first pregnancies. For example, the data that we have in Wales comes from routine data, so we will have the first recorded pregnancy of mum in the data that comes from there, but it's not necessarily the first pregnancy that she's had. I mean, if she's lived in Wales her entire life, then in all likelihood we could get the first one. But it's how sure we are whether that is the first pregnancy or not. But yes, we can do it. But there is a degree of uncertainty there.
And I think that brings up also one of the other questions in the chat, which was saying, what about women who disengage from services? And this is only using existing routine data in Merida. So anyone who doesn't use the services, we don't have their data. I don't know, Danielle and Jenny, what you would say about that.
Yeah, I was going to say on that first pregnancy point, again, if you don't have the abortion data linked, if you don't have data from early pregnancy units, then you won't have data on first pregnancies that present to care. But of course, people might have a pregnancy and never get to care if they miscarriage early, and so you lose that completely. But yeah, because we're using routine data, I've seen questions in the chat around, ethnicity and migration and refugee status. It really depends on the extent to which those things are collected in routine data. And that really varies as, first of all, whether or not they're in there, and second of all, whether or not they are asked and then recorded. In the scoping review, we looked at some of these things and how well they were recorded in the papers that had linked. And in the 272 papers, there was less than a third who presented data on the ethnicity of the people in the data sets that they were linking, about the same looking at deprivation, but then there were only 3 papers looking at domestic abuse, 1 paper looking at refugee status, and 6 looking at LGBTQIA plus identity. So those kind of factors that you would want to be able to look at inequalities and look at different population groups are often not recorded or poorly recorded, which then means you can't. And that is, of course, the limitation of the routine data.
Though different areas in the UK can link to different data sets. So like in Wales, we can link to the census, so we can get ethnicity. In London, there's strong links to mental health data sets. So there different areas actually do have strengths where you can do these things in that local population. So part of it, I think, is finding out what's available in local places, and if there's a specific question, it can be done there.
And perhaps also, Sinead, with the cohort studies that you link with the routine health data. So, you know, born in Scotland or born in Bradford, they born in Wales, they will perhaps reach different communities as well who may not necessarily access health services, isn't it? So the sample size will be smaller, but it will have really detailed data on populations who you may otherwise not reach. And I think there's quite a few comments in the chat, you know, we're excluding people from some of this work, and actually it's excluding those who we need to know most about and who we need to support better. So there's definitely more work to be done there.
I think the other thing is the opt-out. So that came up in our public deliberation. Like, lots of people don't know about the opt-out and thought it should be more widely promoted, that you can opt out of your data, but also why you shouldn't, and that the problems of certain bits of the population being more likely to opt out means you then aren't included in service planning and things. So yeah, there was that kind of desire for people to know that they can take their data out, but to understand why they shouldn't and how their data are protected and why it's valuable for them to be in.
Mana and Noella, you've asked a question about what really makes practice of preconception care difficult, and what are some plans for Africa. So I don't know if you'd say a wee bit more about some of the questions you have in the chat, because I think some of the things presented here about what makes practice of preconception care difficult is lacking the data before the pregnancy, really. And we do have data between pregnancies, but before the pregnancy, like I think, Mike, you were saying, linking to the GP data, linking to the hospital data, that's feasible in some places and not quite feasible yet in other places, but on the way. Isn't that right?
Yeah.
There was a question about what percentage of the existing data sets pertains to ethnic minority communities. So any of the speakers, I mean, I would say picking up ethnicity was the issue.
Yes, so as I said, in the scoping review that we did, about a third of the papers reported on ethnicity from the people in the data sets that they were linking. But it varies, as I said, as to whether it's collected and whether it's included across all those different data sets, whether it's national or regional. And like I say, if you can link to something like census and then you can pull in that ethnicity data, then that's great, but it doesn't always happen.
John Holloway, you were saying about, do any of these data sets link father to the child? I don't know if any of the speakers would find having the father is quite difficult to know. We can link to who's an adult male in the household. So you can look at who a child lives with, but we don't have the biological father. Don't know if any of the speakers would say more about that.
I was going to hope that Mike would say, yes, we do have some data on that. But I think we, at the workshop last year, we did discuss some ways of identifying, like you say, Sinead, like, you know, if there's an adult male in the household, or we'll have to maybe think about creative ways to, yes. So yeah, within the Merida partnership, I think there are various data sources where we can find some clues about linking partners or fathers, however we whatever, you know, they really are, if they are biological fathers or if they're partners or if they're in a relationship with the mum, for example, or part of the family. But yeah, definitely hoping to include that.
I think the only thing that we have relating to fathers at the moment, at least in the Welsh data anyway, is that the births registration data set will record some demographics about dad's his occupation, where he was born, and his social status. But oddly enough, that data only seems to pertain to births where the baby didn't survive, so for stillbirths and things like that. So it only represents about 10% of the data. So that's the only direct data that we have for a dad for any given birth in Wales at the moment. But as Sinead said, we have had colleagues working on algorithms that allow us to look at the most likely sort of male father figure in the household, and we could possibly adapt that if we wanted to look at sort of parental, not necessarily dads in the household as well.
Thanks.
So
I know in the birth cohort, we were recruiting multiple generations. The only way we had a good idea about dads was in the ultrasound clinics would often record mum and dad's names during pregnancy. Difficult.
And we tried linking to ONS, but even that doesn't tell you who the dad is, you know, the father is in the household. There's a question here about, are there opportunities for organisations like health and poverty partnerships already working closely with affected communities to lead elements of this work? So Danielle, your work with Preconception Health Partnership, how would people...
Please get in touch. Yes, definitely. Yeah.
And so part of the reason why, Mike, I don't know if you want to say a bit about Merida and questions and things like that might people
Sorry,
might...
with respect to what? Sorry, I missed the last part you cut out.
Sorry. They're saying about opportunities for organisations working closely with affected communities to lead elements of the work. And so the Merida, I think, is set up in order to encourage questions and encourage working with people to use existing data to be able to answer questions.
Yeah, and I think that's why we've been focusing on putting a lot of our stuff into our GitHub and things like that as an ongoing thing, so that people can see not just what work we're going to be producing and what we're working on, but they can see how we put it together, so they can emulate what we've done if they want to collaborate with us. They can see how, you know, we will have a library of scripts that do certain things within our data sets to bring back certain data, and people can use and adapt those and then contact us for any queries as well. So all of our information is out there. We're working with loads of people already, aren't we?
So ideally, I think through the Preconception Partnership would be, because
it'd be great if people, because we're doing this survey soon in the next couple of weeks, as soon as we have ethics approval, to see what research questions people find important to address, for example, using Merida data, and we'll then doing the workshop to prioritize what those most important research questions are to initially focus on and to collaborate on, and, you know, for people to lead on going forward. So it'd be great to hear from everyone who wants to be involved, what they think the important research questions are and what people would like to lead. That would be great. I'll put my email in the chat if anyone would like to get in touch.
Jenny, you're open to people getting in touch with the policy unit?
Yeah, absolutely. So we work with the Co-Production Collective, and we have lived experience members working on each of the projects, as well as part of our executive group, to make sure that we have that lived experience voice at every level of our work. And yeah, very happy for people to get in touch.
So ideally, this webinar is to try and connect people and to connect people with different expertise to be able to work with others with different expertise from them, for us to move things more forwards. So I actually, please do get in touch with people you can see on the webinar. And let me see. We have similar problems with Northwest ambulance coding, as it's a final impression which is not aligned to guidelines. Paramedics are not diagnosticians, so can avoid putting anything other than pregnancy related problem. So I don't know, Anne, if you'd be willing to say a wee bit more about that?
Hi, yeah, it's something that we're looking at the moment because our maternal outcomes are quite poor across the northwest. We've got some areas in Blackburn and Darwin and Blackpool, and we've got high rates of miscarriages that the crews are attending. We've got high rates of young first-time mums. Often they've disengaged with antenatal care. There's lots of reasons: fear of judgment, just not knowing what they need to do. So often 999 is the easiest call to make. Someone will attend. But we're struggling in accessing things like early pregnancy units. If a woman's bleeding, we can't always get straight access into an early pregnancy unit. Whereas if the woman attended herself, she would get in, she would have access to some of the services. So we've got lots of different work streams going on at the moment, but our coding and things is one of them. We're having to go through and pull out a lot of data through the written text from the paramedics, and often they are documenting postpartum hemorrhage, you know, antepartum hemorrhage, all these different things, but they're just not willing to code it. As I say, our guidance around it, we are moving more to I'm trying to think, the Association of Ambulance Execs, their coding, but it was really interesting watching that talk. Thank you.
Thank you. Last question from Patricia, about in Scotland they're piloting the use of adapted form of one key question about pregnancy intention in order to open a discussion about the importance of preconception health with primary care colleagues in any interactions they have with women. This is linked with information fact sheets. So if anybody would like to know more about that, please get in touch with Patricia. Patricia, I don't know if you've put your email on there for people who'd like to know a wee bit more. And Errol, I think there's quite a bit in the chat for people who have more information about the alcohol end of things. And I think Patricia as well has said that. So, so thanks a lot, everybody, for joining. And hopefully we come back again soon after the preconception meeting and maybe say a wee bit more about what are the questions that people have said these are the priorities that we need to take forward, and then hopefully working with the Preconception Network, with the analysts, to be able to come together and start answering the questions we've all identified. So thanks a lot. And please do stay in touch. Put your, contact other people and get in touch with Danielle and Jenny and Mike if you have any other questions or that. And so we'll be sharing the webinar. We'll be sharing the links and slides if people would like them, and if the presenters are happy to share their slides. So thanks very much. Thanks a lot. The next webinar in a month is research development using imaging. So if people know of others who are interested in imaging, in my case, I'm going there because of ultrasound imaging and learning from those who do the brain imaging, that we can start looking at ultrasounds in pregnancy and linking to what the certain markers mean for the baby in the future. So markers on the brain. We've already been doing markers with the kidney and markers on the heart. So anybody interested in ultrasounds and what those might mean, please do look up the link or just go on the recording after if you can't go on that one. So thanks a lot, everybody, and hopefully see you again soon. Bye-bye.